Hello and welcome to another edition of No Nonsense with Pamela Wallin. Today I'll look at medical assistance in dying and all of the ethical issues that surround this. Of course, the debate has been going on in the UK, and it's interesting when you see another country grapple with this, you realize that it's the same ethical discourse that we've been having in this country for 10 years. The questions are familiar. Will the poor and the disabled and the vulnerable find themselves on the slippery slope? The evidence in this country, fortunately, is quite powerfully to the contrary. How will doctors know that the individual's choice is really that and has not been coerced, or they have been convinced somehow that they're a burden? And how do we personally prepare for aging and what choices or lack thereof we may have? So, quality of life, quantity of life, all of these issues. We've invited two people who spend most of their life thinking about these issues. James Downar, Clinical Research Chair in Palliative and End-of-Life Care at the University of Ottawa. He's a professor, head of the Division of Palliative Care. And Eric Mathison, a professor of philosophy at the University of Toronto, Scarborough, where he researches and teaches bioethics, and he's a certified healthcare ethics consultant and working on a whole lot of issues, even including vaccines. So we want to start there in general, which is our population is aging. There's many, many more of us living longer in sometimes more compromised situations. James, I'll just start with you. Are we ready as a society to deal with this aging bubble, particularly the boomers?
I guess the best answer I can give is that I hope so. I think that we've seen it coming a long way off, obviously.
Yeah.
And I think, yes, we've known for a long time that the demographics of our society are changing. We are aging as a society. We also have a high degree of immigration that tends to come from younger populations as well. So it's probably not going to be the same degree of tsunami, perhaps, that was predicted decades ago. But that said, a lot more and more of our society is focusing on care of the elderly. We are more acutely aware of our need to expand some of our resources, particularly around congregate care settings, assisted living facilities and retirement homes. There are far more people and far more resources going into the care of the elderly. I think we're having a much more, I can tell you that certainly within the research and academic spheres in medicine, there's a far greater emphasis on how the care of the elderly may differ from some of the paradigms and the focus that we've had in previous years in healthcare. That a lot more focus on quality of life, a lot more focus on function.
Eric, you seem to be nodding your head. Agreement?
Yes, absolutely, and that from my clinical ethics work, that I think the attention in the research around the sorts of ethics issues that arise in long-term care and in aging populations, that's getting more attention, and clinically we're just seeing more consults related to those kinds of situations. So there's we're kind of been anticipating it for a while. I agree with James that there's that there are causes for concern, things that we need to worry about and to give even more attention to it. But I think that it's something that's increasingly on our radar.
One of the battles that you hear, and that I've been involved with this for a long time, both on the question of advance requests, but also part of the parliamentary process here. We often hear the argument that the focus on medical assistance in dying, on MAiD, takes resources from palliative care, that we should have a larger focus on that. Again, James, I know this is your area specifically, so is the balance there? We could never see any evidence that we're robbing Peter to pay Paul.
Again, I'll try to keep the answer short, but simply to say that, the vast majority, 80+% of people who are receiving MAiD are already followed by palliative care at the time that they get referred. It's really not an either or. We're seeing increasing MAiD is performed in palliative care settings by palliative care providers. About 20% of MAiD cases are in palliative care settings. About 10% of people who get MAiD get it from a palliative care provider. We are seeing probably the fastest, most dramatic growth in palliative care services in Canadian history over the past 10 years, increasing focus and emphasis. I don't think that we should say job done here. I think we have to say that there needs to continue to be more resources put into this and further growth. But I can certainly tell you that there's no indication on any level here that palliative care is suffering for this having been legalized. I think that you just have to make sure always that understand that what legalizing MAiD was about legalizing choice. That the system should never be focused on the number of people getting MAiD. Everybody should have the options, and we should always be trying to improve those options.
So, Eric, this is where the horror stories set in, that somebody's being wheeled into surgery or arrives in a hospital and somebody unethically says, well, wouldn't you just rather have MAiD and get this over with? I mean, I just don't, for the record, believe 99.9% of this. But how do we figure out when and how we should offer that as an option to people who may not have even considered it?
This has been an issue going back to Carter, that discussion of that. Polls show now that people are more aware of it, but there are still parts of the population that we can't assume that people know that MAiD is an option for them. And so it's a responsibility of the healthcare provider to discuss all of the potential options that might be available to the patient. And that could include MAiD in these situations. So I think that it's for the provider to assess that and do it in a way that is going to describe to the patient that might be an option, and then ask if they want more info. In some cases, when these kind of reports kind of come up in the news, when we get more information about it, it's that it's just that the provider said MAiD might be an option for you. Do you want to know more? And that the person might have misinterpreted that as saying that was an offer, or that was kind of pressuring them into that. So I think that we have to get the balance of making sure that people are aware of it and that can be a thing for them, while also making sure that it's not being seen to be coercive or pressuring them. Just like one more thing is that the MAiD assessment process is about the most thorough process for any kind of end-of-life care, for sure. And so the idea that patients are being pressured into this and they might kind of like unwittingly agree to stuff, that's just totally unfounded. That the assessment process is very thorough in looking for the reasons behind the request, looking for pressure and coercion. So it's just not realistic to claim that patients are getting pressured into this when they don't want it.
You referenced the Carter decision, and I guess the big change that's occurred in Canada after the Supreme Court ruled, which is, in the first place, before you could even be considered for MAiD, your death had to be reasonably foreseeable. You were at stage 4 cancer. This was going to occur, and we were looking for ways that people didn't have to have a painful death. Then the decision comes that, well, it doesn't have to be foreseeable, reasonably foreseeable. It can be inevitable. And then that's where we have to start to wrestle those issues. What's your take, Eric, on where we are on that issue now?
I think that the problems with reasonably foreseeable natural death, that they were justified in rescinding that. So in places that have a time limit, like Oregon or all the other US states where they require natural deaths to be within 6 months. I think that's unethical, that somebody who has the same amount of suffering, who has a condition, but they're going to live for 2 years or maybe longer. It's unjustified to say that somebody who's going to die sooner naturally should be able to access assisted dying just in virtue of that, when if one of the goals is of MAiD is to prevent suffering, that we're saying to these other people who are going to live longer that they can't access it. I think that that's unfair. I think what it's so I think that the change that came about through the Truchon decision, I think that was absolutely the right move.
Yeah, and that's what you hear from a lot of the community of those with mental illness or mental impairment, which is, why are we being discriminated against? We should have access to this too, just because we have a mental health issue. Back to you, James, on that question of reasonably foreseeable versus not.
So yes, Again, I think that it was fairly clear from the start that provision, which was never part of the Carter decision, was going to be really difficult to justify from a legal standpoint. I think from a practical standpoint, it's also really important to understand that this track 2, the people who do not have reasonably foreseeable deaths, is an exceedingly small number. So it's about 2% of all MAiD cases. In Ontario, that number actually seems to be going down, the absolute number, not just the percent. The overwhelming majority of people who get MAiD in Canada would have been eligible for MAiD pretty much anywhere else in the world. So, there's a lot made about the criteria, a lot of discussion about the criteria and what difference that makes. But I think that misses one of the broader points about this, which is that almost everybody in Canada is eligible for MAiD at some point before they die. And only whatever it is, 3, 4, 5% will actually take it. And the people who are eligible and who end up requesting MAiD often would have been eligible sometime before they made the request, but they waited. So the vast majority are people who are really quite close to their natural death anyway. So the notion that again, I think the concept here that's really important is not to think of people as sort of being passive, like sort of gas particles floating around in the system, and we're deciding how much we want to open the valve and let out. In fact, the number one control far and away is internal to the person, and it's when they reach this point that the criteria are by the time someone makes a request, for most people, the criteria are quite easily met, and it's very rare that it's actually controversial.
We have these issues, of course, of geographic access. And in my home province, for example, and I believe this is still the case, that if you phone a hotline, a medical hotline, they've kind of taken references to MAiD as an option off the list of things. So we're seeing some progress forward and some backsliding in terms of just providing everybody with the kind of information they need. Eric, what's going on? Why is that happening?
I think that there's, I guess, political views at the provincial level about access. My home province of Alberta, where I also worked as a clinical ethicist, we're seeing a kind of new resurgence of activity on this issue that the premier is doing these kind of like surveys or just discussions with the community to try to get input on it. But just looking at how not just MAiD but other care options as well, that there are things that the provincial level or that healthcare system to healthcare system that differ, and this is a thing that I think is that there's ways of kind of limiting access, or there can be quite big disparities in access between urban and rural groups, for instance, or province to province, and that's something to be concerned about, and something that is worth taking a close look at.
Well, the obvious example is Quebec really going out there and saying we're doing advance requests. We're going to let people request access to MAiD. This is the kind of catch-22 of an Alzheimer's diagnosis, that you can't ask before and you can't ask once you're diagnosed. And so they've said, no, we're going to have such a thing as an advance request, ask their prosecutors not to prosecute. And even though the practitioners are still vulnerable to the criminal code, even Ottawa seems to be backing off. So, James, what does that signal to you?
Well, I mean, Quebec, I think, has always been out at the forefront on this one, and they've done it, I think, better than the rest of the country because they've done it through parliamentary means rather than being forced by the courts. So they've spent years doing consultations, engaging people, doing education, collecting information. It's very clear that this is a really important issue for a large proportion of the Canadian population to have the ability to make these advance requests.
Yeah, like well over 85%. Yeah.
It's very, very high. And I think, a lot of this stems perhaps from personal experience with relatives and friends, having seen people in situations that we ourselves might not want to be in. I think I want to make it really clear that I think that we want to be careful not to say that every single person who ends up in a situation where they have cognitive impairment and cannot make decisions for themselves is necessarily suffering as a result of that. I think I don't want to give that impression. But I think that it is there are many people who would look at that and say, look, I mean, if I'm in a situation like that, thank you very much. I've had a great life, and this is just not something I would like to continue living with. I think it's a different paradigm than what is currently the state of MAiD, where you're dealing with somebody who is competent is able to give contemporaneous consent for the procedure to say that right now this is what I'm experiencing, and I have an appreciation for how much life might be left to me and what the options are, and of these options I'd like to take this one. We know that when you're trying to make a decision about a hypothetical future state, people often sort of, they're not very good at predicting what they might want in a future state. So there is a limitation there. So it's a fundamentally different paradigm. But having said that, it is not unique to MAiD. So we have crossed this line many, many times and for decades in Canada when we talk about advanced care planning and surrogate decision making. So, a very large proportion of the Canadian population, there needs to be a decision, if you may put it as a life and death decision made for that person at a time when they're not capable of making the decision. So the decision is fully made on their behalf by a relative, a next of kin. Again, we're sort of embracing and understanding within that there's always a chance for the potential that there may be secondary considerations or secondary benefit to the individual making the decision if this person dies as opposed to lives. We may know that there's been very poor communication about what that person's values are and in what situation they might want to continue living. There's uncertainty around diagnosis and prognosis sometimes. All of that is accepted and some studies suggest that as many as 40% of the population finds himself in such a situation before they die already. So I think it's very important to say that as we acknowledge that there are some limitations to how certain we can be about doing advance requests for MAiD, this level of uncertainty is something we have long accepted for equally important, quote unquote, life and death.
Every single person in this country, Eric, that goes in for serious surgery deals with a DNR, a do not resuscitate. You have to have that conversation with your spouse or your mom or your dad and say in what circumstances, do you want to be revived or if you're so impaired that you can't participate in life as you know it, do you want any extreme or extraordinary measures? So we've actually recognized this and accepted this principle for a very long time.
Yes, absolutely, and that we've recognized that there are downsides, as James discussed, or sorry, not downsides, but I guess like complications can arise to address, and that's part of the system. But also recognizing that the approach that Quebec is taking to advance requests, that in many important ways it's much more restrictive than just saying kind of making it the same as an advance directive. That's the approach that Spain took in 2021 with legalizing MAiD, that they just said, you can now, if you want to put in your advance directive that you want MAiD, then you can do that just like you could with anything else. Whereas Quebec system is much more restricted in that you have to be given a diagnosis. It's an agreement with a specific healthcare provider and so on.
How do you wrestle that personally, Eric? And I'll just stay with you for a moment on this issue. This is very personal for me. I watched my mother go through this. I know the genes are in the family pool. I want to make that decision. I've never had any doubt for years, and I can't imagine I would have any doubt. So I want that ability to have an advance request and spell it out. What might I not be thinking about?
I think your situation is absolutely common. That one of the most common comments we got in 2016 when MAiD became legal was people saying, "Okay, great. Now, if I get dementia, now I can have this." And then we had to tell them that would actually probably not be available for them because they wouldn't be able to consent at the time when they otherwise would qualify. So that was a very common point. And as you said, the polling has consistently shown that support for this is very high. So I think the things to kind of that you might not be anticipating or might not be thinking about are that just what the experience is like. What is it actually like to have dementia? That is a question that we can spend time with people with dementia, and experts of dementia can inform us about that. But I think actually like what it's like inside and confirming this is another difference actually. So for advanced directives, you can just if you don't want to have life-sustaining treatments, if you're on a ventilator, then you can say that. But the Quebec legislation requires that the healthcare provider assess that confirms that you have suffering. So you have to be giving signs of suffering somehow, so that it covers these cases that people worry about where you might have an advance request for MAiD, get dementia, but then actually be content. And so it's, that those are the kinds of cases that people are most worried about.
We've had this debate 100 times, James, but that whole concept of happy dementia, right? That the person is sitting there tapping their toe to the music and appear, at least at the earlier stages of this, to be enjoying their lunch or their bed or whatever it might be. But that is not the same as being the person that they once were that made this decision.
So that's part of the question. I think that, people are often envisaging around this that they may have seen a friend or relative who was obviously, like suffering, deeply paranoid or agitated and unable to view any care provided to them as something other than a physical threat. And it's very challenging, to imagine yourself. I think what this person must be experiencing inside of all of that. It's not a question of not supporting them, not loving them. It's you can see the terror in their eyes as you're trying to do even the most basic things to help them. And I think that thankfully not common, although it definitely happened in one of my relatives. But obviously not in others. And so I think we need to, one of the things that is important to convey also is that sometimes people have a concept of, say, well, if I can't recognize my family members, then I would want it. Or if I'm not able to control my bladder or bowels, then I would want this. And people will commonly say things like that. It's important to understand that might sound like a very thick, clear, black line. It's not. So as those of us who have experience with this will know, you'll walk in the room and you have a relative and they'll look at you and they recognize you, but they'll call you, your brother's name or your sister's name, or they'll confuse you with your cousin, or they'll confuse you with your dad. And so they recognize that you are family, but they just got the wrong family member. Does that count? They're good some days, but not other days they can, but some days they can't. They lose control of their bowel or bladder when they get an infection, but then it resolves and gets better. You sort of skirt on this line very often. So I would say you want to be a little bit careful about writing things, imagining that there's a very clear black line that everybody will agree that you're on one side of it or you're on the other and you'll never cross back. I think that the question, and Eric's captured this very nicely, around the idea that, if you look happy and you look comfortable and contented, it is more controversial as to whether, yes, okay, but you're not the person you were. But then what is really the point of what we're trying to do? Is it that when I cease to be the person that I am, then I would want my life ended, versus am I trying to prevent myself from suffering? Now, I have my own views on what that should or shouldn't be, but that's really a societal question. That's not a medical question or a philosophical question. That's what do we as a society think this could and should be used for, and what
But
not.
isn't this where it comes back to your point, to that this is choice? I mean, this is very personal, having watched my mother, who was a very particular kind of woman. She was a teacher and she was a leader and she was all these things, become some completely different person who did not recognize even family members at a certain point. There was sometimes there was sometimes a familiarity, but that would be kind of as like what I came to the conclusion watching that process over 5 years is that was suffering for her, because her brain was not able to do all the things that she would have done at that age and stage if she had not been inflicted with this disease, with Alzheimer's. So although you're not writhing in pain on the bed, if you can't be what you want and need and hope and should be, Eric, is that how do we say that is suffering? And that's my judgment call about it. So that's the part I want to write down and say that's my reason.
And this is the difference, I think, between how Quebec has chosen to craft its approach versus the MAiD in general, that there is a suffering condition that you have to meet, but that it's up to the individual. So they can describe, or they have to be suffering in some form, but it's up to them to decide what that level is. I think a more kind of autonomy-based approach would move toward be more expansive than what Quebec has done, to align it with advanced directives in general, which is that it's not about suffering per se, although that is something that many people care about and want to prevent for themselves, but rather it's about having control over what your life looks like and making that align with your values. So in situations such as advanced dementia, where for some people that fact alone, that's the thing that causes them suffering now, that they might end up in that kind of situation. It's not about physical pain per se. It's about that kind of alignment. So a broader approach would let people make that choice in a more kind of expansive way.
And isn't that okay? Shouldn't we be able to do that?
I think that's okay. I think that if we accept that advance directives are an important way of respecting people and allowing them to, as kind of extending autonomy, we go even further than that with wills, that we're able to decide what happens to our property once we die. So if we think that that's an important part of respecting who an individual is, and we already allow that, as James mentioned, for other end of life and other healthcare decisions, then I don't see that there's an important distinction that would rule out MAiD in those cases.
And, the other thing is, and James, is that, this also has been going on for a very long time in terms of it, before MAiD was even a consideration or a law or a constraint. Doctors and nurses and family members just said, Grandpa, we're just going to let Grandpa go. We're just going to give him a few more pain meds and hope this is peaceful. So we've kind of been building toward this for a while. And then when you start to put the constraints around it, it almost becomes more difficult.
Well, and I think that I would like to think that the scenario you're describing is not that common in many places. Unfortunately, I think that it is, that there are people who for some time did do that and sort of extrajudicially, if you will, or extra legally to do this. And the surveys from around the world, even where MAiD is illegal, where MAiD is illegal, make it clear that this is not an extremely uncommon practice. It happens. I would say, from my mind, it's more about the situation where, okay, if we're going to say, okay, hypothetically, we'll say, no, you're not allowed to do it for this sort of situation. Well, then the question is, okay, so what situations am I allowed to do it for?
Yeah.
And what do I have to do before it's then okay? Or do I have to wait for a complication to arise? Right. So it's like, it would be fine if you had a severe infection or a mild infection and we're just not going to treat it. And then you have to have a process that's maybe a bit prolonged, that may be associated with suffering or loss of dignity from your perspective. So I would say, to my mind, that I would rather hinge the question on, understanding that there's no situation. What are the actual options on the table? Because the actual options on the table aren't to sort of say, well, you're going to continue to live in happiness, even if you're a different person. Mm-hmm. What's going to happen if you're not allowing it in that situation is to say, well, we have to wait for a complication. And again, that's, I think I can see a very reasonable argument both ways on this one. But I think it is important to understand that, yes, these are lines that as we're discussing here today, that we've already crossed many times for quote unquote life and death decisions. And that's a major part of what went into the court's decision on this, is that people, frankly, are allowed to make life and death decisions on that basis, on an autonomy basis. And maybe it's not the decision that you would make, or maybe the decision I would make would be different than the one Eric and you would make. And I'm not saying that it is, I'm just saying it might be.
Yeah.
But that's the point. Why should you have to live the way that I want you to live, and why should I have to live the way that you want me to live?
Yeah. So I was just going to go over, Ron Posno is a fellow that's been on the podcast, and he's worked with Dying with Dignity, and he's been an advocate on this, and he's now entering the late stages of Alzheimer's, but still communicates and still has good days and bads. But, he actually wrestled with this one. He has 8 things when I'm unable to recognize or adequately respond cognitively with appropriate emotion and thought. If I become persistently abusive, either verbally or physically, if I become lost, require physical restraint, present symptoms of acute depression or paranoia or melancholia. You were talking about that, James. If I would frequently experience visual or auditory or tactile hallucinations. I mean, My mom, that used to happen to her all the time. I walked into her room at one point and she said, "Oh, don't step on the girls." And I said, "What are you talking about?" And she had a girls' volleyball team from the neighboring town staying with her in the room in her own mind, right? So she wasn't unhappy about that. But, these are things that indicate, um, you know, that loss of who you are when she wasn't able to eat or dress herself, lost verbal skills. Like, is it possible to have a checklist like that and write it down and have others, Eric, say, okay, she's 5 out of 8. That's pretty darn close to what her advance request laid out.
The system that Quebec has chosen to go with, which again is kind of more restrictive than what it might be, is that it's up to the patient or the individual to, once they get a diagnosis, it's up to them to come up with the criteria, but it's in conversation with the physician that
Right.
that made the agreement. And so the advantage of that is that that physician you can have a discussion about what's likely, what are the kind of most common concerns. One of the things we see with advanced directives, which is a downside, is that you don't have to have those discussions with a healthcare provider. And so we'll sometimes see people with an advanced directive say, I want no heroic measures,
Yeah.
or I don't want to be hooked up to machines. And these are the sorts of things that maybe to them seem quite clear what that means. But in fact, does no machines mean, they maybe had a ventilator in mind, but, does an IV drip count as a machine? And so James mentioned that already, even when we're kind of more granular, it can be hard to kind of identify for sure when they've crossed this line. But that is an advantage of the approach that Quebec is taking, is that will limit that. It'll make it more concrete and more that the healthcare provider will have a better sense of like what are the particular values that the patient is most trying to preserve or most is most focused on, and then align that so that the list will reflect that.
So you have that conversation with your daughter, and then your doctor moves to BC or Texas,
I was on
and then
vacation that week or for a month or
yes,
something.
exactly. So we've got these issues, and the advice I've always received, which is tell as many people as you know, write it down in as many places as you can, have the conversation frequently, not so you're driving people away from the Christmas table or the Thanksgiving table, but to make sure you're up to speed, that everybody knows what you think.
I think that is an important point to make. We do have to recognize that we've got a lot of data, a lot of literature on the process of trying to engage people in having advanced care planning conversations, advanced directive conversations. They are, we just have to be, realistic and say that they are of modest effectiveness, that very often, even after quite what we think are comprehensive conversations, people are left with considerable, disagreement where, if you take a person and their loved one and then ask them a series of questions after a conversation, what would they want in this? And then you ask the person, what would you want in this? The disagreement level is very, very high. They do a little better than a random person on the street who never met you, but only a little better. And so, the challenge is that, when you have sort of vague principle-based conversations, that you are trying to convey a very complex notion to your loved ones. And you say, oh, they understand what I want. And the loved ones say, yeah, we know what you want. And then, of course, they don't. A very specific situation will come up where that's not the case. And so I think what Eric is describing here and what Quebec has done is they've tried to make things as specific as possible, and try to make it not just like one of the conversations that we know happens all the time. But as an intensivist, and I work in the intensive care unit, we're all the time trying to sort of look and talk with family members to try to imagine, what do we think this person would want us to do in this circumstance? And you're very, sometimes everyone feels they have a very, very shared understanding of what that is. But very often, even multiple members of the same family will be quite have quite disparate ideas about what this person really would have wanted. So I think it's important to just be a little bit modest in our expectations of we have to accept that if we're talking about advanced consent, there is always going to be a degree of unavoidable uncertainty. And that's not a new thing, and that's not a reason not to do it. But we just have to, before we embark on this, decide that we're comfortable accepting that degree of uncertainty as part of the process, because it's an issue that is very important. And, again, we're already accepting a degree of uncertainty around many other life and death decisions that get made. You just have to be, I think, very transparent about that.
Well, and you might get hit by a bus tomorrow, like this is the...
Yeah, there's uncertainty, and I think you just have to accept that. With the current MAiD practice, I think it's why that's less of a consideration is because I'm able to talk to the person and assess whether they're capable and have a real conversation with them in that moment. And I think that's why people might view this as being a little bit of a separate issue. And it is different, but again, in a way that is not unique to MAiD and not necessarily something we haven't decided that we can navigate anyway.
Eric, I want to talk to you just for a moment about the MAiD providers, because I've had lots of conversations and they've been here on the podcast. I mean, it's an amazing individual who is willing to take this on. They live literally with the threat of the Criminal Code of Canada hanging over their head at every moment because some other medical professional might disagree, or a family member might challenge it, or whatever the case of whatever the circumstances may be. Do we have to work on that end of it as well and start, Quebec giving this particular government says to the Crown prosecutor in the province, you can't prosecute on this. And Ottawa says, we'll kind of turn a blind eye for now, but things change, political circumstances change, governments change. There's international pressure, all sorts of things. You have immigration and different populations come in with different viewpoints. Like, how do we ensure some protections?
This has been an ongoing issue. I mean, back to reasonably foreseeable natural death. This was something that MAiD assessors and providers were, very concerned about. That because it was so vague that it was they were worried that they were going to inadvertently run afoul of the law.
Yeah.
And so I do think that a serious downside of I think that the experiment they're embarking on is a good one, and we should watch it closely. I think it's in the right direction. But a downside of their approach of just saying, well, we're not going to care about the criminal code for this issue, that I think that's a risky move, and it does put it puts those providers in in a bit of a riskier spot because, as you said, things could change. So I think that's something to be worried about.
Yeah. So what, they just have to kind of take it on for now and say, well, we're going to go ahead and do this because we've got a promise, but you could have a prosecutor come up any day that says, I'm sorry, the law's the law.
Yeah, absolutely. I think that's a serious worry, and then that's for patients that's a concern that we don't know what this is brand new, so we don't know how this is going to play out as broader political winds change.
Yeah, we asked this question sort of at the time that just this was came into effect, James, and it was, so what are we going to have medical or MAiD quote unquote tourism to Quebec? They have put rules in about residency, unlike where, you could get on a plane, I guess, and go to Switzerland or Belgium or other places and access this. So what advice do you have for people who want to have some certainty around this?
Well, I think this is an issue that obviously is part of the broader context of how we discuss all sorts of policy. And I think, there are people that have felt passionately about this for a long time and have engaged politically. And my advice would be continue to engage politically. I think that, there are aspects of this debate where I think these are legitimate, reasonable points of disagreement or concerns about how safeguards work. But again, you earlier asked about, whether information provision or offering of MAiD, and what do we do to stop this? Well, the reality is that there are a lot of people that don't know it's an option. And if I've routinely just baffled when people seem to suggest that ignorance is somehow a safeguard, right? Like we should try to drive these numbers down by making sure that as few people as possible are aware of them, so that it's only
crazy.
those who have this degree of agency can access it. That is a morally reprehensible attitude, in my opinion. I think that everybody should be aware of information, and this should always be part of an open discussion. And the idea that people will just be pushed towards MAiD because somebody brought it up, I think that's just ignorance of the process and how these conversations actually happen. But I think bigger questions around sort of how we what should happen legally from a provider. Can you imagine what a position that puts you in, where the province, there's overwhelming multi-partisan support for this provision in Quebec, popular support for this in Quebec, but then if somebody wants to actually do it, they kind of are taking a chance, and it's really up to the discretion of the prosecutor whether to take you to jail. I think we need to start being grown-ups about this and say that either it's legal or it's not legal, and follow the set of rules. But a provider who is in good faith acting on something that is written down and passed by an elected body that governs their jurisdiction should follow the rules. You don't have to agree with the rules. None of us necessarily, I don't agree with every single law.
We don't agree with all the rules out there, exactly.
But I follow them. And if this is what the laws are, they should be followed. And if this is what Quebec's decided, that should be followed. I have no patience. I have no time of day whatsoever for people who feel that having this sort of duality of laws and conflicting laws, and that therefore this should fall on the sort of individual provider at the bedside to have to negotiate, whether what they did was a medical act or should land them in jail for 15 years. That is madness, and I would say indefensible.
The first place, it seems, and for those of us trying to deal with this legislatively, I mean, there's kind of two tracks. There are court cases that seem to have way more impact than the ability to change the laws, because then the government has to act. And Ottawa has done a couple of 180s on these issues, whether it involves mental illness or advance requests. I guess what we really need to do in terms of that making choice available is, to the very least, say to the federal government, take it out of the criminal code and make it a decision between a patient and his or her doctor, Eric. Is that like the simplest thing to do?
That is
Well, not simple, maybe.
It's a simple thing to do, and I think that we have there's that framework could work well. That in kind of other contexts, that for abortion, taken out of the criminal code and that system, I think there are similar access concerns and other things, but I think that overall that system has worked very well. So we've been on this track of from Carter, that now it really takes kind of Parliament will pass a bill and then it takes court challenges and so on. So I don't foresee that cycle ending anytime soon. But I do kind of pine for a system where we could simplify it and ultimately, I think that the data that we have, and there's been so much stuff in the news lately with the Ontario data coming out, concerns about MAiD provisions and so on, and there is just all of the data shows that this system is working extremely well, that MAiD providers are, on the whole, doing a good job following the rules, and that it is preventing the kinds of concerns that people claim are going on, but that I don't think the evidence actually supports.
Yeah, this notion that somehow you can walk in off the street to a Veterans Affairs office or a street clinic and say, my time's up, and some doctor would say, oh, okay, how's an hour? You have to be educated about how restrictive our system really is still today, James, on that front.
Well, yeah, and just to pick up on Eric's point, I mean, in the wake of the release of this data from the Ontario Coroner's Office, the data itself was absolutely crystal clear on a number of points. MAiD recipients are far less marginalized than people who are dying naturally. We knew that before, but this further underscored it. What we didn't know was have data specifically on this track 2, the non-reasonably foreseeable deaths. And again, the data once again heavily underscores this, that the degree of marginalization in that population is no different than people who are dying naturally and not choosing MAiD, people who are living with neurodegenerative disease. You have to understand that this really, I think, puts to bed that question of whether this is happening. It doesn't mean that marginalization is never one of many factors in any case. But even as they reviewed the individual cases where they, they could not, there was one case mentioned in some description about, housing being a factor, and the majority of the committee agreed that but housing was not a factor in this case. That the patients with comorbid psychiatric illness were well followed and well assessed and well managed by psychiatrists. But yet we continue to hear this sort of, what I would say is a fairly consistent signal of misinformation, because it makes for good headlines to say that all these things are happening, but they're not happening. When you look at the oversight,
actually shows if there's a skew, it's a skew the other way. It's people who have income and the ability to travel maybe to another city, are actually people who are freer to access it than somebody living in a tent city with a mental illness.
I think that's a very, very important point to make here, right? And that as we move on, right, that as people are starting to more and more increasingly raise questions of whether, social supports or inadequate social supports or services might be prompting this, even though the data aren't showing it. But I think the obvious question to say then is, okay, what then, is the solution to your solution to inadequate social supports is to restrict MAiD access? That makes no sense at all. The obvious solution to this should be, because we know that inadequate social supports, we know that social determinants of health are a major driver of death, not by MAiD, by natural means. And that if this is something we're concerned about, if we're actually concerned about the marginalized, if we're actually concerned about the disability community, which represents over a quarter of the Canadian population, then we should do meaningful things to actually improve this. We should, things like universal basic income or negative income taxes, improved housing benefits for people, expanding our pharmacare system, dental care, and reducing costs for people who are the most marginalized in our system. That will actually address their needs. And I think this sort of hijacking of the conversation and policy discussions around MAiD in this way, is sort of, it does a dual disservice both to the disability community and the marginalized, but also to the MAiD discussion, which, we really should be talking about some of the things that you've been talking about here today.
Just a final point to you, Eric, on the ethics surrounding education on this. And this is a bit of a complicated question, but, we deal with religious hospitals that may have a moral or religious resistance to not only just providing the service, but even talking about it. There's a lot of blowback about what we're doing in the education system in terms of offering all these alternatives, if it's, for young kids, about gender issues and all the rest. How do we ensure the education while keeping within the, coloring inside the lines on this issue, and not asking people for whom this is a huge moral question to engage in this or engage in the misinformation side of it, as James says also exists? What's the line there?
The fundamental reason that we should give access to MAiD for people is for autonomy, so that they can have control over their lives. The manner and timing of their death is an important thing that many people care about. But also from the beginning, it has been clear that this is not something that we are trying to encourage people to do. It's not something that we are hoping to force on people. There's no evidence that that's happening, and so it's clearing space that. As James said before, that if this is something that you want, then we'll give you info and we can provide it for you. But if it's not something that you want, then you shouldn't be, then that should be the end of the story. I think in the healthcare system, MAiD is one way that it raises important questions about conscientious objection for individual providers. It raises important questions about for faith-based institutions, whether they should be able to refuse to provide MAiD and abortion and other things within their walls. But ultimately, about misinformation, that there has just been so much it's just been an avalanche lately of every new thing that comes out. I read about this on a regular basis, and James is also extremely prolific in kind of trying to address this. But just more and more that it's getting kind of separated from the facts actually as they are, and it's impossible to keep up with. So I don't know what the broader solution to that is, but I do think that the misinformation, and this is to say like about misinformation, like just the basic facts, not about like kind of ethical disagreements or other things, but just actually like what the data show, that there are prominent people who are just making, I think, committing statistical malpractice by making deductions that just simply do not follow from the data that we have. So I think that this, is part of a much bigger conversation about societal issues right now. But MAiD is certainly getting swept up in it.
I have this poem that someone sent me about advance requests. I got it in 2016, and it still sits on my desk. I'm just going to read it. Just bear with me. It says, I fear drowning not in the ocean, a lake, or a pool, for I can hold my breath and swim. I fear drowning not in my vices, addictions, or mistakes, for I confess them each and every day. I fear drowning in the plaques and tangles of my dying brain. I fear drowning into oneself like my mother did as her children watched her disappear. I fear Alzheimer's. And when I read that, I think we have so much more education to do, so that people can deal with these issues every single day, but also then do something constructive about it, to reach out, to have somewhere to turn, to get an answer. So I want to thank you both for being two of those people, so that people can read you and find you, and thank you for wrestling some of the ethical and moral issues around all of this.
Thank you.
Thank you very much.
Yeah, thanks a lot. James Downar, Clinical Research Chair in Palliative and End-of-Life Care at the University of Ottawa, and Eric Mathison, Professor of Philosophy at the University of Toronto, Scarborough, where he researches and teaches bioethics. Just really appreciate it, both of you. Thanks so much.
Thank you.
And thanks all of you for listening. That's it for this edition of No Nonsense with Pamela Wallin. We'll talk again very soon.